will present my talk today is about stroke in children. It is a difficult subject about the stroke in children and how can we deal with these cases. There are challenge in clinical diagnosis, challenge in investigation, and challenge in treatment. I will talk about in brief. It is means that only older adults have a stroke. Stroke can happen to anyone at any time, including teenagers, children, newborn, and unborn babies. The risk of a stroke in children is greatest in the 5 years of life and during the period of right before birth to right after birth. Stroke remain among the top 10 causes of death in children. Every child neurologist, and it is very interesting, every child neurologist should know how to care for pediatric stroke. What are the causes of stroke, pediatric stroke? Stroke occurs when the blood supply to the brain interrupted to reduce. This deprives the brain of oxygen and nutrient, which can cause the brain cell to die. A stroke may be caused by a blocked artery, ischemic stroke, or the leaking or bursting of a blood vessel, hemorrhagic stroke. Can a baby have a stroke? Yes. Stroke is a risk factor for babies with congenital heart disease, blood disorders such as sickle cell disease, infection, including meningitis and encephalitis, premature babies whose blood vessels are more fragile can suffer bleeding in the brain known as hemorrhagic stroke. Can a child have a stroke? Yes. In sickle cell disease, the blood cells cannot carry oxygen to the brain, and the blood vessel leading to the brain have narrow or closed. About 10% of children with sickle cell disease suffer a stroke. There is a high risk of repeated stroke, but that can be reduced by blood transfusion. What about the common risk factor? While high blood pressure and irregular heart rate beat and hardening of the arteries are rare in children, the common risk factor in stroke in children include congenital heart defect, sickle cell disease, immune disorder, disease of the artery, among blood clotting, head or neck trauma, and this is very important neck trauma, which is called pencil arterial dissection. If the children or the pupil in the schools run with a pencil in their hands, and all of a sudden it may be trauma to the neck and leading to the carotid artery and known what is called dissecting carotid artery. Maternal health of infertility, maternal infection, premature rupture of membrane during pregnancy, pregnancy-related high blood pressure in mothers. But what about the symptom of stroke in children? It's very difficult because the child cannot express himself about the complaint rather than the adult. So they know symptom because people don't think about newborn, and there is little information about the symptoms or sign of stroke in children. And the ignorance of the children having stroke, they are not interesting to recognize or treatment properly. Another challenge with newborn is that they cannot communicate symptoms that are already visible. The common stroke warning sign fast used to identify stroke in adults can also be used to identify stroke in children by raising both arms of the child, and if one stand out still and the other drop, it means there is weakness in this arm. And can we stimulate or painful in the face or every side of the face, and if there is division or no division, we can know there is this facial pain. But there are some specific symptoms, and also there are specific or unique symptoms that physicians should look for in children depending on their age. In newborn and infant, seizures, and seizure is more prominent in pediatric stroke rather than adult stroke. Extreme sleepiness, tendency to use only one side of their body. In children and teens, severe headache, especially in case of hemorrhage, vomiting, sleepiness, dizziness, loss of balance, and coordination. What about the complication? Seizure, raised intracranial tension, hypertension, aphasia, skeletal deformity, long-standing deformity. It is very important to differentiate between the focal neurological symptom due to vascular and the other focal neurological symptom, because if there is a stroke, it is need and a hurry or quick interference. What about this? Focal cerebral ischemia, intracranial hemorrhage, abscess, encephalitis, brain tumor, alternating hemiplegia of infancy, multiple sclerosis, malingering, complicated migraine. What about spirits? What about the clinical challenge? Many stroke mimic, which need MRI for differential diagnosis as demyelinating migraine and tumor. Children cannot articulate symptoms. Adult caregiver, children don't have stroke. Infant fail to localize. This is a very important clinical challenge. Stroke mimic characteristic of child disease table show figure show the characteristic of childhood stroke versus stroke mimic. Stroke mimic means other like stroke but not stroke. Focal sign alone, focal sign and others, altered level of consciousness, seizures. About this is a timeline needed for diagnosis emergency department, and it's very, very interesting. If the child seek medical help within minutes, arrive to hospital, initial imaging, and the interference with treatment. What about the neuroimaging challenge? CT plan to rule out hemorrhage. Diffusion weighted MRI of the brain, MRA, MRV, if sinus thrombosis is suspected in cases of headache, convulsions, and high fever. But MRA safer versus CT, but CT angio better diagnosis, but hazardous. Whether DSA, digital subtraction artery, definite diagnosis, but invasive. So MRA safer, but the more important localization and more important neuroimaging is CTA, but hazardous, versus and DSA diagnosis, but invasive. Sedation is required in children, but be careful. These are numerous lesions involving the cerebral white matter of both hemisphere and particularly the left basal ganglia, and it is an infarction. 7-year-old girl with sudden onset of severe right-sided headache, followed by left hemiparesis and slurred speech of 1 day duration. It is about increase in head right, it is an infarction. MRA, as mentioned before, showing narrow right MCA. 5 years male child with history of left-sided focal seizure with secondary illness. Again, there is a focal seizures. Right frontal gray and the white matter atrophy with minimal prominent of CSF, this old infarction. Right supraclinoid artery is almost completely occluded, so the MRA is very important to exclude or to disclose the stenosis artery. CT versus MRI showing evidence of intracerebral hematoma. FLAIR demonstrating acute infarction. FLAIR is very important and is very needed to exclude other causes or to disclose or to pick up early acute infarction within a superficial dissolution. There is cortical swelling and hyperintensity and adjacent portion, subcortical involvement within the right MCA. This restricted diffusion is entire corpus callosum and brainstem anteriorly, as well as the left frontal region, is suggestive of hemorrhagic infarction with subacute hemorrhage. Smooth, regular again, smooth, regular, concentric distal, left internal carotid, and the proximal pre-bifurcation M1 segment flow attenuation. What about so? I've mentioned there is challenge in clinical diagnosis, challenge in investigation, and a challenge in treatment. Children usually recover better from stroke than adults. because the brain are still growing, and it's very important. We can compensate other area or other infarct area or diseased area by good rehabilitation to reinstitute or to compensate the damaged area. However, children can experience permanent complications from stroke, such as seizures, weakness, and vision problems. Treatment for pediatric stroke depend on the specific cause. Others need urgent treatment or other intervention. Some common treatment used with adults are not appropriate for young children and infants. Current treatment for pediatric stroke include supportive care to maintain normal blood temperature, body temperature, proper hydration, and normal blood sugar level, controlling high blood pressure, detecting and treating seizure with EEG monitoring and anticonvulsant medication, managing intracranial pressure, blood transfusion for children with sickle cell disease. Avoid extreme hypertension, but in children don't know what the optimum blood pressure is for maintaining perfusion. Because as we know, there is a correlation between mean arterial blood pressure and cerebral perfusion pressure and vascular resistance. This question is very important in adults, but in children, we cannot detect it. What about the optimal blood pressure for maintaining perfusion? There is a debate about antithrombotic therapy, which refers to medication used to prevent blood clot from forming a growing used in children, but generally not in infants. So antithrombotic is not suitable for infants, but may be interred in children. Start antiplatelet or antithrombotic medication immediately in the children who present with stroke. One of the best treatment for ischemic stroke, as we know for adults, is TPA, or tissue plasminogen activator, drugs that dissolve blood clot. With children, there is a controversy and debate and need further study. With children under 18, use of TPA is controversial and currently limited to clinical trial. Further study on safety and benefit of this treatment is necessary. Is TPA appropriate for pediatric stroke or not? I discussed with this issue with a company who produced TPA, and they haven't any guideline or evidence-based for use of TPA in stroke. But there are some individual experience in this. Children treated with TPA are at risk of intracranial hemorrhage and may be more susceptible than adults to the drug potential neurotoxicity. In addition, TPA break down the blood-brain barrier, may increase lesion size, and may lead to systemic bleeding. So it is very, very rare used TPA in children. But it may be safe and effective to administer TPA to child, but this treatment should be given with safety guidelines. Children may need the higher dose, more than 0.09 milligram per kilogram, because they have less TPA at baseline. Adults have a base TPA, so it is suitable for this dose. But children have no base TPA, so need more high dose or more high dose plasminogen activator. Furthermore, children have a larger volume of the solution and more rapid hepatic clearance than adults. That means more or clearance or rapid metabolism, so need a higher dosing than adults. What about surgery? Surgery related to hemorrhage stroke and less commonly ischemic stroke is sometimes performed to relieve pressure on the brain. As we know in the adult, the malignant infarction or MCA infarction need decompression and craniotomy. So about else, rehabilitation method, pediatric stroke survival also not clear and require further clinical trial. It's important to evaluate and treat children with acute stroke efficiently and accurately. All children should receive neuroprotective measures. It's reasonable to consider treatment with advanced thrombolytic and endovascular agent. Secondly, prevention is very important. How big is the problem, recurrence, current practice, and answer and the need for research. Rehabilitation, acute inpatient rehabilitation, post-acute outpatient, important of family and psychosocial. Reintegration, the central importance of extending rehabilitation. And so it is one of the needs of rehabilitation program and specific rehabilitation program for stroke, either in adult or children. Take-home message, contrary to what most people believe, stroke can will and do happen in children, infant, and unborn babies. There are two age categories for pediatric stroke. Prenatal, which refers to the last 18 weeks of gestation through the first stage, that means intrauterine stroke. Treated after birth, other term for this age period before birth. Neonatal and newborn for birth through 1 month of age. Childhood into 1 month to 18 years. Recognition of stroke is often delayed or even missed in children. Stroke is a common as brain tumor in the pediatric population. Stroke is one of the top 10 causes of death for children. Of the children surviving stroke, about 60% will have permanent neurological deficit, most commonly hemoptysis or hemiplegia, which is the most common form of cerebral palsy in children. Both a term and stroke is its leading cause. Other long-term disability caused by stroke in children include cognitive and sensory impairment, epilepsy, speech, communication problem, and poor quality of life. So it's called disability or handicap. The Pediatric Stroke Program early CT scoring aspect scheme has proved accurate and useful in identifying stroke size in the middle cerebral artery territories or head computed tomography and in the estimation of likelihood of occurrence of symptomatic intracranial hemorrhage following treatment with TBA. Magnetic resonance image and diffusion weighted image for the collateral, especially are even more sensitive. The size of the diffusion weighted image abnormality was found to correlate directly with the likelihood of symptomatic intracranial hemorrhage following TBA therapy. What about the endovascular? And this question is for you because you are interested for endovascular. Endovascular therapy and thrombectomy in children with acute stroke is clear or not? This is my question to you. Thank you for your intentions, and I hope to be joined with you. Thank you, Professor Osama, for my invitation to talk about the brief, and I just like through a light about the pediatric stroke. Thank you, Professor Osama.
Thank you, Professor Fathi Afifi. You are really one of our Egyptian godfather in neurology in Egypt, and thank you for sharing us this very interesting lecture. And we hope that we will be in the next meeting. And I have a question for you, Dr. Fathi. You said that
I need an answer about the endovascular.
Yeah. No. It's related to your talk, of course, Professor. It's about the specificity and sensitivity of fast escape